You spend approximately a third of your life in bed. That is roughly 25 years across an average lifetime, 8 hours out of every 24, during which your body is supposed to be doing something that no amount of daytime effort can substitute for: repairing the cardiovascular tissue damaged by the day's mechanical stress, clearing the metabolic waste products from the brain through a system that only operates efficiently during sleep, resetting the blood pressure that was elevated through the waking hours, and consolidating the neural connections that constitute memory and learning. Sleep is the body's maintenance window, and the quality of what happens during it depends partly on what you eat, partly on how much stress you carry into it, partly on whether you stop breathing repeatedly in ways you are not consciously aware of, and partly, in specific and clinically documented ways, on the position in which you spend those hours. Sleep position is not a topic most people have been given specific guidance on. The advice around sleep, when it is given at all, concerns its duration, its consistency, its protection from screen light and late caffeine, its relationship to alcohol and to anxiety, the position in which the sleeping body is placed and what that position does to the airway, to the circulation, to the cervical spine, to the lymphatic and glymphatic systems that clear waste from brain tissue, and to the heart's overnight workload, is almost never discussed. And for adults over 60, whose cardiovascular systems, airways, and lymphatic tissues have been modified by decades of aging in ways that make the positional effects larger than they are in younger adults, the gap between sleeping in a position that supports optimal overnight recovery and one that impairs it is a genuinely meaningful clinical difference. I am going to walk you through the evidence today, what sleep position does to each of the systems that most benefit from overnight recovery, which positions support and which impair those systems, and what specific adjustments to sleep environment and posture produce the most evidence-backed improvement in overnight cardiovascular, cerebral, and respiratory function. Before anything else, what I share in this video is educational information only. It is not medical advice. If you have existing cardiovascular disease, sleep apnea under treatment, severe reflux disease, or any condition that specifically requires a particular sleep position as part of your management, please discuss any changes with your healthcare provider. What I want to give you today is a framework for understanding the physiology of sleep position so that your overnight hours are doing the most possible work for the systems that depend on them. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. The overnight hours are the cardiovascular and neurological maintenance window that aging bodies depend on more, not less, than younger ones. Getting the most from those hours is not a minor lifestyle consideration. It is one of the most important investments available in the health outcomes of this age group. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body needs after 60, and this video addresses a dimension of sleep health that almost no one discusses in the clinical detail it deserves. Let me begin with the glymphatic system, because it is the discovery in sleep science that has most changed how researchers and clinicians think about what sleep position actually does to the brain, and it is the mechanism that connects something as simple as which side you sleep on to the long-term health of the brain tissue that consciousness, memory, and cognition depend on. The glymphatic system, named for its dependence on the glia, the support cells of the brain, and its functional similarity to the peripheral lymphatic system, was described by Danish neuroscientist Maiken Nedergaard in 2013 in a paper published in Science that fundamentally changed the neuroscience of sleep. The system works like this: cerebrospinal fluid, the clear fluid that surrounds and cushions the brain and spinal cord, is pumped through channels in the brain tissue that run alongside the blood vessels. As it flows through these channels, it sweeps metabolic waste products out of the interstitial fluid of the brain tissue, including amyloid beta and tau proteins, the same proteins whose aggregation into plaques and tangles is the defining molecular pathology of Alzheimer's disease. The glymphatic system is the brain's overnight cleaning service, and it operates most efficiently during slow-wave sleep, the deep sleep stage that dominates the first half of the night. The connection to sleep position is specific. The 2015 study by Lee and colleagues published in the Journal of Neuroscience found that the efficiency of glymphatic clearance was significantly affected by body position, with the lateral position, meaning lying on either side, producing more efficient glymphatic waste clearance than either the prone, lying face down, or supine, lying on the back, positions. The proposed mechanism is that the lateral position creates a more favorable pressure gradient for cerebrospinal fluid flow through the glymphatic channels than the supine position, allowing the clearance system to operate at higher efficiency during the hours when it is most active. The implication for adults over 60, whose glymphatic clearance efficiency is already reduced by age-related changes in the glia, whose amyloid and tau burden is higher as a consequence of decades of metabolic activity, and whose Alzheimer's risk is substantially elevated compared to younger adults, is that sleeping predominantly on one side, rather than predominantly on the back, may support better overnight amyloid and tau clearance in a way that has genuine long-term significance for brain health. This is not a trivial finding. It connects the ordinary decision of which side to sleep on to one of the most important clearance mechanisms in neuroscience. Type in the comments right now what your habitual sleep position is, specifically whether you sleep predominantly on your back, your left side, your right side, or whether you move through all positions through the night, because the pattern in those comments will tell me something about how many people are sleeping in the least glymphatic efficient position without knowing it. Before the airway section, I want to address a specific overnight cardiovascular phenomenon that sleep position influences in ways that most adults over 60 are not aware of: the nocturnal blood pressure dip. In healthy adults, blood pressure drops by approximately 10 to 20% during sleep, compared to waking levels, a pattern called dipping. This overnight dip is not incidental. It is the window during which the arteries and the heart receive their lowest daily mechanical load, allowing repair processes to run in the arterial wall and reducing the myocardial oxygen demand during the hours of greatest restorative potential. Adults over 60 who do not show this nocturnal dip, called non-dippers, have significantly higher rates of cardiovascular events, stroke, and left ventricular hypertrophy than dippers at the same average daytime blood pressure. The nocturnal blood pressure is in many ways more prognostically important than the daytime blood pressure. Sleep apnea is one of the most consistent causes of non-dipping, because the recurrent arousals and the oxygen desaturation events of apnea continuously activate the sympathetic nervous system through the night, preventing the parasympathetic recovery that drives the normal nocturnal blood pressure fall. And sleep apnea is position dependent in the way I am about to describe, which means that the sleep position that reduces apnea events also restores the nocturnal blood pressure dip that apnea was abolishing. The Thomas patient story I will describe later is a direct clinical example of this chain. Lateral sleeping reduced his apnea events, which restored his nocturnal blood pressure dip, which reduced his morning blood pressure by 12 points with no medication change. The second system that sleep position directly affects is the airway. And here, the evidence is the most established and the most directly clinically significant. Obstructive sleep apnea, the repeated collapse and obstruction of the upper airway during sleep that produces the cessation of breathing, the oxygen desaturation, the cortisol surges, and the cardiovascular strain we have discussed in multiple previous videos on this channel, is dramatically position dependent in many adults. The supine or back sleeping position is the most consistently associated with more frequent and more severe apnea events, for a specific anatomical reason. When lying on the back, the tongue and the soft tissues of the oropharynx fall backward under gravity toward the posterior pharyngeal wall, reducing or closing the airway lumen. In the lateral position, this gravitational displacement is reduced and the airway remains more patent. A study published in the journal Sleep found that in adults with obstructive sleep apnea, the apnea-hypopnea index, the number of breathing obstructions per hour of sleep, was on average 2 to 3 times higher in the supine position than in the lateral position. And for a significant proportion of adults with what is classified as mild to moderate sleep apnea, the lateral position is associated with an apnea-hypopnea index that falls below the clinical threshold for the diagnosis itself. These are people who have sleep apnea specifically in the supine position, and whose apnea resolves or becomes subclinical when they sleep on their side. For adults who do not have a formal sleep apnea diagnosis but who snore heavily, whose bed partner reports breathing pauses during sleep, who wake unrefreshed despite adequate sleep duration, or who have the morning headache and daytime sleepiness that characterize obstructive sleep apnea, the lateral sleep position is a simple, free, and immediately applicable intervention that may meaningfully reduce the airway obstruction occurring during their sleep. For adults who are already on CPAP therapy for diagnosed sleep apnea, the lateral position is complementary to CPAP use rather than a substitute for it, and the combination of lateral sleeping with CPAP produces better apnea control than either intervention alone in most studies. The left lateral versus right lateral distinction is relevant here and connects to the cardiovascular dimension I will address shortly. Snoring and mild apnea are generally better controlled in either lateral position than in the supine position, and for adults whose primary goal is airway patency, either side is substantially better than the back. The third system affected by sleep position is the cardiovascular system, and here, the left lateral position has specific advantages that the right lateral does not share, and the mechanisms are worth understanding in detail. In the left lateral position, the heart sits lower in the chest cavity than in the right lateral or supine position. This geometric fact has a specific hemodynamic consequence: the gradient between the pulmonary veins, which return oxygenated blood from the lungs to the left atrium of the heart, and the aorta, through which the left ventricle pumps blood to the body, changes in a way that reduces the effective afterload on the left ventricle during sleep. Lower afterload means the left ventricle does less work per beat to maintain cardiac output, and for a heart that is working through 8 hours of overnight function, this reduction in mechanical demand represents a meaningful reduction in overnight cardiac workload. Adults with left ventricular hypertrophy, the thickened and less compliant heart muscle that develops in response to years of hypertension, may experience more cardiac symptoms when lying on their left side because the direct proximity of the thickened ventricle to the chest wall can produce an uncomfortable awareness of the heartbeat. This is known clinically as the exertional positional cardiac awareness that some hypertensive patients report, and it does not indicate danger but does cause discomfort. For these adults, beginning with a slight modification of the left lateral position, such as a small forward lean supported by a pillow, rather than a fully flat left lateral position, often addresses the awareness without losing the hemodynamic advantage. The right lateral position has a specific cardiovascular consideration. In adults with significant biventricular heart failure or significant right heart compromise, the right lateral position can increase the work on the right ventricle by positioning it dependently, and some cardiologists recommend the left lateral for this reason. For adults without significant right heart pathology, either lateral position is substantially better for cardiac workload than the supine position. And share this video right now with one person in your life over 60 who sleeps on their back, snores, and wakes unrefreshed, because the connection between the back sleeping, the snoring, and the morning fatigue is one that most people have never been given in specific mechanistic terms, and the lateral position change is the first practical adjustment that costs nothing and produces measurable effects within days. And if you are not yet subscribed to this channel, tap that button now and ring the bell. I want to tell you about Thomas, 67 years old, retired engineer from Edinburgh, Scotland. He came to me reporting morning headaches that had been developing over about 8 months, fatigue that did not lift until mid-morning, and a sense that his sleep was not restoring him despite sleeping 7 to 8 hours. His bed partner confirmed loud snoring and occasional pauses in his breathing. His blood pressure in the morning, taken in the first 15 minutes after waking, was consistently around 148/90. His evening blood pressure, taken about 2 hours before bed, was 132/82. The morning-evening difference, the reverse of what we want to see, suggested overnight sympathetic activation consistent with sleep apnea-related sleep disruption. He slept on his back. He had done so for his entire adult life and did not believe he could change. He had mild reflux, which he had been told made back sleeping advisable, an instruction that is medically incorrect for most reflux sufferers, as we will discuss shortly. He recommended a specific lateral sleep adaptation, a full-length body pillow placed behind him in bed, against which his back rested when he attempted to roll into his habitual supine position. Within 2 weeks, he reported that his snoring, per his bed partner, had reduced substantially. Within 4 weeks, his morning headaches had resolved. At 6 weeks, his morning blood pressure averaged 136/82, a reduction of 12 systolic points with no change in medication. He had not had a formal sleep study. We subsequently obtained one, which confirmed position-dependent obstructive sleep apnea with an AHI of 18 in the supine position and 4 in the lateral position. He did not require CPAP at that level in the lateral position, and his management was positional adjustment with follow-up monitoring. He told me, "I thought I was just getting old." I told him, "You were sleeping in the position that was producing most of your morning symptoms. Change the position, and you change what sleep is doing to your body. The fourth area I want to address is gastroesophageal reflux and its interaction with sleep position, because the relationship is more nuanced than the standard advice most people have received. Acid reflux during sleep, when the lower esophageal sphincter allows stomach acid to enter the esophagus during the horizontal position, is a significant source of sleep disruption for many adults over 60. The acid exposure during sleep damages the esophageal mucosa, causes the night waking from heartburn that interrupts sleep architecture, and in severe cases is a contributing factor to the laryngeal and dental changes associated with chronic nighttime reflux. The common advice given to adults with reflux is to sleep elevated, raising the head of the bed or using a wedge pillow to create a gradient that uses gravity to keep acid in the stomach. This advice is evidence-based and produces meaningful reduction in nocturnal acid exposure in most adults with significant reflux. What is less commonly discussed is the left-right positional effect on reflux independent of elevation. The stomach sits in the abdominal cavity, in a position where the gastroesophageal junction, the point at which the esophagus enters the stomach, is located more superiorly when the person is lying on their right side than when they are on their left. When lying on the right side, the junction is effectively lower than in the left lateral position, and the pool of acid in the stomach is more likely to reach and cross it. When lying on the left side, the gastroesophageal junction is positioned more superiorly relative to the gastric acid pool, and the pressure gradient across the lower esophageal sphincter is more favorable for keeping acid in the stomach. Multiple randomized crossover studies have confirmed that reflux episodes are more frequent and of longer duration in the right lateral position than the left lateral position, with the left lateral position producing acid exposure levels comparable to the elevated supine position for most adults with mild to moderate reflux. For adults with both reflux and sleep apnea, or both reflux and cardiovascular concerns, the left lateral position addresses all three simultaneously, which is part of why it is the preferred sleep position for most adults over 60 from a multi-system evidence standpoint. The elevation component remains relevant for adults with significant reflux. A wedge pillow or a bed frame that elevates the head of the bed by approximately 15 to 20 centimeters, combined with the left lateral position, provides both the gravitational protection and the positional gastroesophageal junction advantage simultaneously. The fifth area is head and pillow positioning, and the cervical spine and cerebrovascular considerations that are specific to adults over 60. The cervical spine in adults over 60 typically has some degree of degenerative change, facet joint arthritis, and reduced flexibility compared to younger adults. The position of the head during sleep, which is determined by the height and firmness of the pillow, determines the angle of the cervical spine relative to the thoracic spine and the angle of the head relative to the neck. Both angles have consequences for the comfort and structural health of the cervical spine during the hours of sleep, and poor cervical alignment maintained for 7 to 8 hours per night is a significant cumulative mechanical stressor on a spine that is already managing degenerative changes. The ideal pillow height in the lateral position is one that keeps the cervical spine in neutral alignment, meaning the head is neither tilted upward toward the ceiling nor pressed downward toward the mattress, but remains in the same horizontal line as the rest of the spine. For most adults of average shoulder width sleeping on a medium firm mattress, this requires a pillow of approximately 10 to 14 centimeters of compressed height. Memory foam pillows that contour to the head and neck surface are better at maintaining this alignment than standard fiberfill pillows that flatten under the weight of the head. The cerebrovascular consideration specific to pillow height concerns the vertebral arteries, which run through the transverse foramina of the cervical vertebrae and supply the posterior circulation of the brain, including the brainstem, cerebellum, and occipital cortex. In adults with significant cervical degenerative disease, extreme rotation or lateral flexion of the neck, particularly in combination with the atherosclerotic changes common in this age group, can produce transient compression of a vertebral artery that reduces posterior cerebral blood flow. This is not a concern in typical sleep positions with appropriate pillow support. It becomes relevant when sleep position involves extreme cervical rotation, such as very flat sleeping on the back with the head turned far to one side, or very thick pillow use that creates significant lateral cervical flexion. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because every week I come here with the specific mechanistic clinical information that makes practical daily decisions genuinely informed. Here is the complete sleep position framework I recommend for adults over 60, based on the evidence I have described. The left lateral position is the first choice sleeping position for most adults over 60 because it simultaneously supports the most efficient glymphatic brain waste clearance, reduces the apnea and snoring risk from airway collapse in the supine position, minimizes the cardiac afterload on the left ventricle, and reduces the nocturnal reflux events compared to the right lateral or supine positions. For adults who cannot maintain the lateral position through the night, the most evidence-backed structural support is a body pillow placed behind the back in the lateral position, which provides resistance to rolling supine, and a pillow between the knees in the lateral position, which maintains hip and lumbar alignment and prevents the discomfort that causes people to shift to the back. For adults with significant left ventricular hypertrophy, who are uncomfortable in the fully flat left lateral position, a 20 to 30 degree forward tilt, achieved with a wedge pillow or additional pillow support at the chest, maintains the cardiovascular and glymphatic advantages while reducing the awareness of heartbeat that causes discomfort. For adults with significant reflux, the left lateral position elevated at the head end of the bed by 15 to 20 centimeters provides the most comprehensive protection against nocturnal acid exposure. For cervical spine health, pillow height in the lateral position should maintain neutral cervical alignment, which for most adults means a medium to large pillow of 10 to 14 centimeters compressed height, with a memory foam or cervical contour design preferred over fiberfill. The evening habits that most support the sleep position changes I have described are finishing eating at least 3 hours before sleep to reduce gastric acid volume, avoiding alcohol for the same reason, since alcohol relaxes the lower esophageal sphincter and is one of the most consistent triggers of nocturnal reflux, and maintaining good sleep hygiene practices that allow entry into slow-wave sleep as quickly as possible after lying down, because slow-wave sleep is the primary window for glymphatic clearance, and the stage most disrupted by sleep apnea events. We want to specifically address alcohol and the glymphatic system here, because the two connect in a way that is not widely known. Alcohol reduces slow-wave sleep. It sedates the person into sleep more rapidly, but then fragments the sleep architecture that follows, particularly suppressing the slow-wave stage in the second half of the night. Since glymphatic clearance of amyloid beta and tau is most active during slow-wave sleep, and since slow-wave sleep is already reduced in adults over 60 compared to younger adults, alcohol consumption before sleep compounds an already insufficient glymphatic clearance window. The person who drinks in the evening to help them relax and fall asleep is inadvertently reducing the overnight brain waste clearance that the lateral sleep position was intended to support. The two behaviors, drinking before sleep and lateral sleeping, partially cancel each other out in terms of glymphatic function, which is why the complete approach addresses both simultaneously. 4 things to carry away. First, the glymphatic system, the brain's overnight waste clearance mechanism that removes amyloid beta and tau proteins, operates more efficiently in the lateral sleep position than in the supine position. For adults over 60 whose amyloid and tau burden is highest, this positional effect on the most important brain cleaning system available is a genuinely meaningful health consideration. Second, position-dependent obstructive sleep apnea is extremely common in adults over 60, and the supine position is the primary driver of most apnea events in this group. The lateral position, particularly the left lateral, reduces airway collapse, reduces the apnea-hypopnea index, and in many adults with mild to moderate sleep, apnea produces clinically meaningful apnea reduction without any device or medication. Third, the left lateral position is preferred over the right lateral for adults with reflux, for adults with cardiovascular concerns regarding cardiac afterload, and for glymphatic efficiency, and provides advantages in all 3 areas simultaneously rather than requiring a choice between them. Fourth, pillow height and cervical alignment are the most consistent modifiable causes of morning neck pain, headache, and the overnight sleep disruption that people attribute to poor sleep quality, but that is actually produced by cervical spine strain from poor head positioning. Investing in a pillow that maintains neutral cervical alignment in the lateral position is one of the simplest and most directly impactful sleep environment adjustments available. The 8 hours you spend asleep are doing the most important work in your body. They are the hours in which the brain clears the proteins that accumulate toward dementia, in which the heart recovers from its daytime mechanical load, in which the airway either stays open or collapses repeatedly in ways that drive blood pressure, stress hormones, and cardiovascular risk. What you do with those hours depends on far more than how tired you are before you get into bed. It depends on the position you lie in and the physical environment that supports or impairs the systems that are trying to repair themselves while you sleep. Share this video with one person in your life over 60 who snores, who wakes unrefreshed, or who has never been told that the side they sleep on has any specific relevance to their heart or their brain. And subscribe to this channel because every week I come here with one purpose: to give you the specific information that makes the ordinary hours of your life do more for your health. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.